fine. Ritzo.
Ritzo, all right.
Easier to pronounce than me.
She'll be talking about hospice. The topic of the day is hospice does not mean you are giving up. Let's welcome Christine Ritzo.
Hi, everyone.
Good morning.
Good morning.
Good morning.
And again, happy Veterans Day to our veterans. Thank you.
Thank
very
you.
much. How many of you have had any experience with hospice? Terrific. That's a lot. And how many of you have had positive experiences with hospice? That's good too. Do any of you, when you hear the word hospice, have any fears that pop into your head?
Used to.
Used to.
Used to.
Okay, all right, and only one person still does, and that's quite understandable. So I am here to talk about why hospice doesn't necessarily have to be a scary, bad word. In our lives, we have a circle of life, and we have a lot of celebrations and preparations that we do through that course of life. We celebrate our birthdays and our anniversaries and first communions and bat mitzvahs and weddings, and planning for the rest of your life, even at the end of the life, is a good thing to do, and it gives people control, and that's a lot of what hospice caregivers like to be able to give a patient and their families is control over the rest of their lives, as much as possible. So the hospice concept is all about comfort. It is about providing someone with quality for the rest of their life, even though that life may be limited by a life-limiting illness. And what else did I want to say about that? And a lot of that has to do with symptom management. People often have life-limiting illnesses and may have the option to have chemotherapy or radiation therapy or surgery to get rid of whatever physical disease process is causing the illness. But if they can't have that option, that doesn't mean they can't be comfortable still. And sometimes people do have options, but perhaps they're older, perhaps they're just very, very weak, and they don't want to go through those kind of options. And sometimes for those kind of patients, they'll come on to hospice and have symptom management, get their strength back, get those symptoms under control, and they actually graduate off of hospice and go back to do whatever treatment was available for them but they didn't have the energy for. So going on to hospice doesn't mean that you have to climb into bed and just prepare to die, because often people do get stronger, their symptoms are controlled, and they do graduate off, and you can use those benefits over and over multiple times. And a lot of people don't know that. And it gives them great relief to know that it doesn't necessarily have to be the end. Many of our hospice patients, when they use their transfer part of their benefit, it isn't because they're dissatisfied with services, it's because they're transferring to another hospice either 50 miles away or 3,000 miles away to go on a vacation or a short trip. You know, maybe a last trip, but that's okay. We'll transfer them to a hospice wherever they're at, so even while they're on vacation, they can have that 24/7 nursing coverage, either by triage nurse or someone coming out to the home. So you don't have to be homebound to use those benefits either. What you do have to do is have some doctor saying that they are making an educated guess that you might be in the last 6 months of your life. That is okay if they're wrong. Many of the doctors do make an educated guess that someone is in the last 6 months of their life, and then they get on hospice and their symptoms are controlled much better than they were initially, and so that decline is a little slower, and that's okay. Some people are on hospice for a year or two. Some people graduate off once or twice during that time frame. I had one aunt in her late 90s that didn't want to be treated for pneumonias anymore. And so She was 96 and said, she was having a lot of swallowing issues, and she said, don't give me any more antibiotics for it. So we didn't put her on hospice. She still graduated off twice. She was a little frustrated, but that was okay. We had a couple more years of enjoying each other's company, and life went on. I do want to, I did mention the qualifiers for hospice. I am more than happy to talk about what people are involved with the hospice care and what the benefits are about if you want me to. Or I can answer questions now and then we can kind of go and fill in from there. What would you like to do? I see questions.
I have a question.
Okay.
So I know nothing about hospice.
Okay.
So are you a private company that...
So the overall philosophy of hospice, there are many hospice agencies. Yes, I do work for Mission Hospice and Home Care, which is the oldest hospice in San Mateo County, and it's the only independent nonprofit hospice remaining on this side of the bay from San Francisco down to San Jose. But in general, hospice is about bringing care to people wherever they live.
So what's the cost of hospice?
Hospice is covered always under your Medicare benefits, and most often under all of our insurance benefits, even if we're not 65 and over.
Really?
Yes, yes. So under the Medicare benefit and even the private insurances for the rest of us often mimic the Medicare benefit. So under the Medicare benefit, it is the most generous and liberal coverage that you have. The least restrictive. They cover the visiting doctors and nurses and social workers and volunteers and bereavement teams and the bathing people to come into the home.
So this is not 24-hour care.
So the nursing support is 24/7 as far as the visiting nurses come to your home on a scheduled basis. But if symptoms or problems arise in between those visits, families are able and caregivers able to call in and either speak to a triage nurse or a nurse can come out to the home. So even if it's 2 or 3 in the morning and there's a symptom issue that hasn't been able to be controlled by the families or caregivers, the nurses can talk them through some things on the phone, and if needed, still send a nurse out during the middle of the night. So it is very generous as far as that goes. It's very generous with getting equipment, which is quite easy under the hospice benefit. Oxygen, hospital beds, walkers, wheelchairs, anything needed. Whereas for the rest of us just coming out of the hospital after a surgery or something, if you need any equipment, it's like pulling teeth right now. So it's nice coverage for that. Some, if not all, of the medications are covered under the hospice benefit as well. Anything for comfort or symptom control of anxiety, shortness of breath, pain, agitation, anything for comfort is covered under the hospice benefit. Yes, sir.
A question, caregivers. Do you have caregivers that either your company or another company provide, and not the medical team, but caregivers that are there, for a period of time during the day, not 24 hours, but maybe 8 hours or something like that?
Caregivers, Mission Hospice and Home Care does not have a separate caregiver agency. Some agencies do have both home health and home care and the caregivers. There are plenty of caregiving agencies out there, and legally, when we give a recommendation for caregiver agencies, we have to give 3 or 4 at a time.
Okay.
But there's pages and books, and if that's something you need, I'd be happy to help you with. Caregivers, those custodial people that are there with you either several hours in a day or day in and day out, doing the bathing, the cooking, the feeding, the dressing, and all of that, is never covered under our insurance benefits unless you have a long-term care insurance policy, and then you'll have some coverage for that. But not too many people have long-term care insurance, but it comes in handy if you do.
And the hospice people, I mean, normally, I guess the general public looks at hospice as the end of life, okay?
Yes.
I mean, and the people that, go into the hospice type of care, from the hospital, this type of thing. How do you handle them, because they're dealing with the end of life normally, say 95% of the time? I know some people graduate out of it and that type of thing, but what kind of care do you give them? I mean, what type of support do you give, them, because they're dealing with the end of life all the time?
Care, are you talking about the patients and
No, I'm talking about
families, or the hospital team?
The hospital team.
Oh,
I mean,
okay.
because that's got to wear on them after a while, I mean,
Sure.
plus when they get to know the people and they get to know the family and that type of thing, and it's day in, day out, and they pass, and I mean, that's got to affect them.
It does. Honestly, you see people passing away in the hospital less and less these days, simply because that's not something the government wants to be paying for. So they really press, and it's kind of sad, but they really press hard on the physicians to get people out of the hospital before they pass away. And sometimes it's appropriate, sometimes it's not. When patients are in the hospital and they're using their hospice benefits, because there is a level of hospice benefits that allows you to be in the hospital if symptoms are out of control and you can't be anywhere else. Our hospice teams work with the staff there. Once you're in the hospital using your hospice benefit, the hospice team is kind of the lead as far as directing the medications and things like that. And then the emotional support is added as well. And that goes out to the nurses. They have guidance from our nursing team, the doctors, and the medical social workers, and our bereavement and spiritual teams to handle any of their emotions on that too.
Okay.
But it is happening less and less, just because that's not necessarily the ideal place for someone to be passing away in a clinical setting.
Yeah.
Yes, they're
So,
waiting.
a certain percentage of the reverse mortgages I do are for medical care.
Yes.
And what always surprises people is that a reverse mortgage only lasts for about 2.5, 3.5 years, because people are paying out at a rate of $20,000 a month for non-medical care. So my question to you is, while I'm sitting with these clients and we're talking about how long this is going to last, is hospice something that could step in and reduce that cost burden for them and make that money last longer? Or should I direct them to talk to you folks and find out what's possible?
Certainly, hospice could reduce some of the cost burden. What is covered under the hospice benefit, aside from the people coming in and doing the house calls and seeing them, is some of the medication. Like I said, it's some, if not all of their medications can get covered under that benefit. Pain medicines can get quite expensive sometimes. Incontinence supplies are covered under the hospice benefit, and I don't know, a lot of you have probably had children and grandchildren, and a lot of you probably have older parents as well, but incontinence supplies can be an easy $500 to $1,000 a month
Right.
in and of itself. So that can help decrease that cost burden. And then the equipment, you're not having to rent it.
Right. The
It's-
hospital
it's
beds
covered.
and wheelchairs, the
Yeah.
cranes if they're
Yeah.
bedridden. I mean,
That's awesome.
the hospital, I mean, and they will deliver, I mean, like immediately. They come in with a truck and they
Hospice
set it all
delivery
up.
of equipment is a lot easier. It's usually 4 to 6 hours during the week and maybe 6 to 8 hours on the weekends. But they try to plan ahead on what you may need.
So you're San Francisco to San Jose, did I hear that, or
So Mission Hospice is San Mateo County.
San Mateo? Okay.
Yes, and a little bit of Santa Clara County north of 85, but founded in San Mateo County in '79, and that's mostly our focus. Yes.
I'd like to share my family's experience. The last year of my life, my mother was in hospice, and she lived comfortably with dignity in her own home, a home that I helped my father build in 1977 in Belmont. And the last day of her life, she went shopping with my sister and rode around in a little cart, and they went to lunch. And this hospice was nothing but a positive experience for the entire time. And the thing that I really value was it was dignified, it was comfortable, she was in her own home, and she died in peace.
It sounds like her wishes were heard.
And she graduated a couple of times from hospice during that year, but I have nothing but good things to say about it.
That's lovely.
And it's really wrong because people call this a death panel and other stuff. That's just wrong. This is a program that is wonderful.
Thank you. And that's the way it should be. When families are connected early on with the hospice support, I find it much more beneficial for the patient, for the families, and for the caregivers, because when you're asked to start hospice care and it really is maybe the last 48, 72 hours of someone's life, if that's a lot of people coming in at the last minute to try to get symptoms under control, and usually it's just very focused on getting out of control, symptoms under control, so someone is comfortable, but they don't have that kind of long-term benefit of getting to know the person and what their goals and wishes and desires were. The upside, even to connecting with hospice, even in the last couple of days, is the person's bereavement benefits continue on for the family and the caregivers. So even if it's 6 months or a year or two later and someone calls in to, well, when they call into Mission Hospice and say, you know, I'm not quite over this, I don't know, they think there's something wrong with them, and there's not typically something wrong with them. Everybody grieves differently, but they still have the ability to use that person's benefits to talk things out, either over the phone or face-to-face or through one of the group community sessions. So that is a gift that keeps on giving, even for those short-term kind of cases. It can help the family and the caregivers in the long run. Yes?
So when should someone contact hospice, and what's a trigger?
So the joy of my job is oftentimes families or doctors will call in and say, you know, I think we need help, but I don't know what we qualify for. And oftentimes the doctors will have a question in their head. They think maybe the person might qualify for the hospice benefit, but they're not sure. So they'll say, go out, look, you tell me. And that's the fun part of my day, is to meet those families and see the patients. But when you're seeing someone coming in and out of the hospital frequently, or just kind of having the dwindles, you know, it's not major issues that come up, but slowing down, becoming more homebound, becoming less interactive, not wanting to get out as much. Those are early on indicators. Sometimes it is the changes in their mobility. It's harder and harder to get to the doctor's office. They are getting just more fatigued trying to get to the doctor's office. They come home and they sleep another day because they're exhausted. And then again, listening to someone's desires. If they're telling you, you know, if something comes up, I really don't want to be going back and forth to the hospital anymore. Those are kind of things to hear and say, let's see what's available. Within Mission Hospice, it was founded as a hospice in '79, and as a spin-off several years back, because the community board that runs Mission Hospice was seeing a need for capturing symptom management, palliative care patients that weren't hospice eligible but still had the symptom management needs. That's when our home care program was a spin-off. So we could capture those people that maybe are going through their chemotherapies and radiations or just post-surgery and recovering and have symptom management needs. We can address those through that. And then they also, the community board targeted some of our donors' monies to a transitions program for those people that might be in the last couple of years of their life, don't really have active home care, home health needs or hospice needs, but could benefit from some guidance and listening, emotional support from the social workers and a volunteer. So we have a community-funded transitions program that allows the medical social worker and the volunteer to get connected with those people early. And if they do need nursing evaluations, the outreach team that I'm on gets to go in and see those. And I was telling someone earlier this morning, I met just the most lovely 98-year-old lady on Wednesday evening that probably is not hospice eligible. Her neighbor thought she might be and arranged for a family meeting with the patient and her family. She's probably not hospice eligible, and she didn't have the skilled needs for the lower level of home care. But at the very least, she will benefit from the transitions program. She sat down in front of me and she held court with her family and her neighbor that were there and myself, and just talked and talked and talked. And it's harder for her to get out, and the family is there as much as they can be, but that's hard to do. But she clearly needed some socialization, and she had plenty of stories to share after 98 years. So that's fun when you're able to connect people like that, just with some support, and knowing at 98, the odds are she's in the last decade of her life. Yes?
Are you affiliated with visiting nurses and hospice?
No. Well, visiting nurses and hospice have their own hospices.
Okay.
So in overall globally, we're all under the visiting nurse hospice umbrella, but
Okay.
specifically not associated with what used to be visiting nurses and hospice in San Mateo. That actually has gotten absorbed, like most agencies. We're the only one in San Mateo, as I said.
Are they part of Sutter Health?
Yes.
Is that right now?
Yes.
Okay.
They
Who
are.
pays for the nurses that come out?
Medicare.
Medicare, okay.
Or our insurances, for
So
those of us that
what
aren't
do your
Medicare.
volunteers do?
Oh, the volunteers. Oh. We have direct care volunteers that come into the homes and work with the patients right at the bedside, whether it's reading or recording their life history, just being present. At one point, my aunt was very interactive with her volunteer and loved the volunteer to come and read to her because her eyes were failing in her late 90s, but she loved reading. And then in her last series of hospice, she would wait for the volunteer to come and then tell the volunteer she was going to take a nap, and she would hope the volunteer would be there when she woke up. And so it was just a need to have someone in the room. And God bless that volunteer, because it gave my mother and I the opportunity just for a couple of hours, a couple of times a week, to not be there with my aunt. And so the volunteer at that point would just bring her crocheting and her own reading and sit and read, and she was just present. My aunt would wake up and smile and say, "Thank you, you can go now," and it was all good. But the volunteers either do direct care, or our volunteers also do a lot of our community representation. The auxiliary does all the benefit gala planning, so there's something for all of our volunteers. And any kind of interest you have. It doesn't have to be hands-on in the home with the patient. I have 1 minute.
Final question.
Yes.
I'm asking these questions for you, Jim.
Oh, okay. Thank you.
Is that it?
I need a little bit about your the organization. It's a nonprofit. I know you're down on Amplet Boulevard.
Yes.
And
That's where our offices are. But obviously our teams are out all through San Mateo County. We have 5 medical directors that divide up patient caseloads and do house calls on them. We have a 6th one that does night call coverage periodically. And then we have our nursing team, we have our medical social worker team. They're the people that either help with paperwork and planning. Sometimes sometimes families want them to plan a whole funeral mass for whatever denomination or non-denomination patient is.
so a lot of those kind of charges would be beyond Medicare, I would imagine.
No, those are all covered under the hospice benefit.
Wow.
And then the medical social worker team, I say, is the emotional right arm for the patient, family, and the caregivers. And then you have your bathing attendants, your volunteers, our spiritual and bereavement teams, and they are equally as outstanding. And a lot of that support, like I said, continues on even after someone's done. And I'm more than happy to answer questions after this.
How's the company funded?
Mission Hospice is funded by insurances and a lot by community donation. And we even have a Mission Hospice house, a physical place that opened up a year ago that is largely funded by community donations too, and that's in downtown San Mateo. And that's a small place we use for some people when they need end-of-life care and families or caregivers can't quite do it at home at that point, the last couple of weeks of life. And so I'm happy to talk available another time.
You might see if you.
It is used for respite periodically, as long as there's a bed available. So get on the waiting list, because I know you have an aunt with Mission Hospice. So get on the waiting list for that, and if it's planned and there happens to be a bed available. Otherwise, the medical social workers will find a respite place.
What is respite? Thank you, thank you.
Thank you very much, and thank you for donating the book in Mission Hospice's name. I did put that.
Thank you.